Welcome to the Masters of Critical Limb Ischemia second session. I think this session is going to be presentation of cases by experts, followed by a brief discussion, if feasible, if Tony allows time. And these are technology-based, and the idea is to show best practice use of such technology. And there's no one better, in my view, to talk about laser than Dr. Tony Das. Tony, this is the microphone for the speaker, and this is your clicker. And are you going to take on the round circle on the stage?
Of course, why not?
Wonderful.
This is the forward and back.
And there is a laser pointer.
Great.
So Dr. Tony Das is going to present on peripheral intervention using laser.
All right, Subhash, thank you so much, and congratulations to the organizers of this meeting. I'm just so proud of you guys, having developed this meeting now for 8 years, and it's very hard. I was talking to Paul a minute ago to try to do 3 different disciplines in a meeting like this. So in the next 8 minutes or so, I'm going to talk to you a little bit about laser. Everybody in the room is probably familiar with laser. There are 2 lasers that are out there. I have really no conflicts specific to this talk. And one of the things that's clear is that, I guess, the understanding laser mechanics and laser physics. If you don't understand these, then you won't know where it's going to be used best. In fact, the case that we saw this morning that Dr. Mahmood did, actually, laser could have uncovered what the situation was, maybe because of these 3 effects that it has: photochemical, photothermal, and photomechanical. And I'm going to show you how this works clinically. All right. There are 2 different lasers we use on a regular basis, one from Philips and one from Orion. And essentially what we know is that they have slightly different wavelengths. And part of the difference that's interesting about them is one's a solid state and one's this xenon chloride gas, which makes the system a little bit bigger. But the Orion also has aspiration, which actually comes in pretty handy in some cases. And I'll show you an example of that to follow. Where are the places where I think that laser really does the best? One is it changes a few things. It changes compliance, it uncovers culprit lesions, it helps avoid stent placement, and it's approved for in-stent restenosis, and it helps with thrombus. So if you have cases like this, which I suspect almost all your cases would have something like this, you should think about laser. Now, let's talk about a case. This is a 71-year-old patient, usual risk factors, has an ulcer, ABIs are low, 0.5 on one side, 0.4 on the other, low toe pressures. The patient was seen in an outside facility, and I think that it's important to just take a look carefully at these outside images. This is an old case, but I think it's worth reflecting on a little bit. The patient self-referred for a second opinion. This is the images that we got from the outside, and as you can see, really not great tibial flow. AT is open on the right, PT and perineal are gone. Most of everything else is gone on the left except for the posterior tibial. But the idea was this patient was going to get an amputation. And so when we saw this image, we thought, really, let's see if there really is something to uncover here. So laser was a thought process for me, at least looking at this. So what did we do? Basically went into the right TP trunk and anterior tibial and the posterior tibial segment and opened up this segment with a 0.9 laser and then a 1.4 millimeter laser. And we were using the understanding of the physics, the photochemical effect. Carbon-carbon bonds were being broken apart. Some thrombus was being removed. And with 2 passes, it looked like that. I would have never thought that that left panel could have looked like that right panel with 2 passes of laser unless you start to understand the physics of how laser works. And then with a simple balloon angioplasty of the AT and also that segment that I'm pointing at right there, this is what it looks like and down into the foot. So these are the places where I think it's useful. Here's some other places where I would not want to put drug-coated stents in the tibial vessels on a regular basis. We saw a really interesting case that Dr. Lee and Dr. Shishabor showed us earlier. But if that's the runoff that you saw up there on the left, would you consider even at all putting a drug-coated stent there, because you would think that the outflow would keep it from staying open? But once the anterior tibial and the perineal TP trunk segment is wired, a 0.9 millimeter laser, and you can see there's 2 wires in and lasers being used. So this is one of the few devices that you can actually have a wire next to you and still use, so that's an advantage. And then you can see it uncovers the lesion there in the 4th panel, and then a bifurcating stent is placed there using the typical techniques we use in the coronaries, and that's the result you get. The other thing that you can do in these, and this is the third case, is uncover lesions that are thrombotic. So in the case that you saw this morning, where there was this long segment, it was ballooned, it looked like there was a lot of thrombus. One of the things I like to do is when I see something like this, where there's a thrombotic occlusion, I want to know, is the lesion just right there, or is it the entire segment? Because you can see this area. Using a 2.0 laser after wiring this segment, what we saw was that uncovering the lesion gives me this look. So I can tell that the lesion's not 30 centimeters long, it's more like 100 millimeters long, and that 10 centimeters is basically able to be ballooned and ultimately, if needed, to be stented. So now we've taken the other two physics features of laser, which is producing the thermal energy and the photomechanical effect, giving me a sense of really what's going on in that vessel. So it helps in a lot of ways to be able to tell. Why? Because laser effect on thrombus and platelets is direct. The higher the fluence, which is the first number in the recording of the laser, the higher the fluence is, the more platelet aggregation reduction you get, ADP platelet aggregation. So this is a graph that basically says, if I use higher energy, I'm going to put platelets to sleep. If that happens, you can also find that other devices might be helpful. So this is a patient with a diseased, and you can see the osteomyelitis on her toes. There's a pedal arch which is incomplete, which ultimately gets crossed, and then this is the use of the Orion laser. This was in the Pathfinder trial, and that registry was then published and showed that you could take this 0.9 millimeter laser, and you can see it in the left panel up here, and it's real small, but it's making its way around, all the way around the pedal arch. So I couldn't get a balloon to cross here, but that little dot right there is the movement of the Orion laser, and ultimately it allowed a balloon to pass, and then this is the final result. So with that, what we know is that laser allows us to really look at complex disease below the knee and above the knee and uncover what the real lesion is. It gives us a more precise understanding about the lesions, and that way we can treat them more effectively. And if we don't know if thrombus exists, we can uncover the lesion by resulting in a decrease in platelet aggregation. And using these three effects, keep them in mind: photochemical, photomechanical, and photothermal. And go back to your physics classes, and you can see that these synergistic effects have a lot of great outcomes on these type of lesions. Thank you very much.
Tony, that is the microphone for the next speaker. Hold on to it. Yeah, but I will ask you a few questions. We have a few minutes for discussion. Sure. And so question is that, when do you choose to use which of the two lasers? Because I don't understand the difference between them in a way to know, do I need both in my lab? Should I have one or the other? Or if I'm a regular laser operator, I should have both options available?
That's a great question. We usually go by who the strongest person in the lab is on the day that we're working. So if there's somebody who is able to move the larger laser, that's the one we usually choose. No, I'm kidding. So I think for us, it's a matter of having both technologies, because we were in the Pathfinder trial, and I think it helps for us to have something that also adds the ability for aspiration. So the 2.0 laser of the Orion laser gives us that aspiration capability, and it is helpful. It even more uncovers. The other thing is that these two wavelengths are not just random numbers, 355 and 305. If you look at the interaction of these lasers with different types of plaque, the more fibrotic disease in the solid state laser actually you can get through, the more thrombotic disease is better with the Philips laser. So there are little subtleties that you get to learn over time. If you had to choose one, then just choose one. They both are effectively similar, but I think if there's subtleties that you learn over a long time of doing laser, you may choose one over the other, and we have both in our lab.
One quick question for June. June, in your lab, do you have laser? And you know, my first exposure to laser was with Tony for very early in my life, learning how to cross occlusions. If you remember, Tony. So is it something we use today? And then this is a question for June, but not to put her on the spot, but in general comments about CTO.
I have used both lasers. We currently actually have both systems. We historically had the Philips, and then more recently have been trialing Ariane as well. There are some nuances to either of them, and I think there are advantages and there are disadvantages potentially to both. Interestingly enough, with the Ariane laser, the waveform actually the wavelength doesn't react with contrast. So if you need to do the granuloplasty, that's the wrong one to pick. You actually need the Philips laser if you are purposely trying to fracture, say, for example, a chunk of calcium. To that point, I have used laser as a step-by-step method of crossing a very tough CTO proximal cap. So if you're planning for step-by-step, it may be more advantageous to pull a Philips laser so that you can actually do a granuloplasty as a bailout if you need it.
That was an intentional question to you because the mechanism that Tony spoke about, how wonderful it would be to see it in action when you do intravascular OCT imaging to understand the different ways these two lasers work or there are differences. So that is a great idea, and maybe in the future.
There's one more difference. For radial operators, the Ariane laser has a 220 centimeter laser where the Ischemia doesn't have it. So if you want to do a radial to peripheral with a laser, just make sure you pull the right one.
Great points. Great points.
All right, our next speaker is Dr. Sam Sayfo. I have particularly great pleasure in introducing Sam. So Sam did his interventional cardiology fellowship with us in Brown and has obviously gone on to do us proud, has become a major voice in the peripheral space and has really pioneered R2P in the peripheral space. And Sam is going to talk to us about orbital atherectomy. Sam.
Thank you, Peter. So thank you so much for having me today. Thank you for the organizing committee. So I was asked to present a few cases and discuss orbital atherectomy. By raising hand, who has done orbital atherectomy? Yeah, so orbital atherectomy, the last time it was checked, is the most common atherectomy device available in the United States or used in the United States. And if you look at atherectomy in general, I think this is, just to cover all atherectomy. You notice there is certain atherectomy devices that are better for certain cases. So as Dr. Das has mentioned, if you have instant restenosis, you're limited for basically laser and maybe Rotarex. If you have severely calcified lesions, you may have to have either the laser, especially super dense, maybe CSI is the right answer. If you look at this, just to summarize, most of the trials for orbital atherectomy, and I don't want to go by one. Most of the trial has been, they're older trials, but if you look at for example, the Compliance 300 trials, there's significant less stent bailout comparing to the PTA, which makes sense because when you soften the calcium or minimize the sharp edges, you have less stent placement. At 6 months, there's a significant reduction of TLR, but that did not prove to be accurate for the 1 year. And there's other trials, the confirmed trial, the calcium 300 trials, but for orbital atherectomy, the way we look at it when we use it is more when calcified lesion. You have to have moderate severe calcification before this device can be used. Otherwise, you're really not targeting the right atherectomy for the right lesion. I'm going to go over a few cases, different challenges, different approaches. This is an 83-year-old male, history of SFA intervention with IVL and draconian balloon 2 years ago. Had a worsening claudication. His right SFA was heavily calcified. That was one of our first few cases that we done R2P, radial to peripheral. And when you look at the angiogram, the first picture you look at it, you're like, this is maybe not the first case you should do. And when you look at this, how heavily calcified that lesion, you want to make sure that you do some kind of calcium modification. And in this situation, the orbital atherectomy offer a 180 centimeter shaft, 1.75 burr, and this is what we end up doing. And at that time, you can see a good result there. You could have just, DCB it and leave it alone. But in 2019, 2020, we did not have a DCB that 200 shaft. So we end up deploying a stent there with a 7 by 150 or 120 Terumo stent, and this is the final result. The reason I want to show this case is that stent in this area is a self-expanding stent, but to make sure that the stent will stay patent, and this is 5 years patency so far in this case, is you have to prep the vessel very well. Stent is not the solution, because if you have calcium, especially nodular calcium, the stent will not, and the stent cannot expand well, your stent will not stay patent. What about another case? A discussion that I love to have it here today, because common femoral artery intervention has been challenged over the last few years because the advancement of technology we had. The traditional way is to send patient for surgery. We're having more sicker patient, older patient, maybe patient where surgery might end up with some complication. This patient, for example, is 65-year-old female, severe claudication, and she had a pelvic radiation therapy for a uterine cancer. She had bilateral claudication, bilateral severe common femoral artery stenosis, and she ended up receiving a gold standard therapy with a common femoral artery endarterectomy. Unfortunately, that was complicated with a non-healing wound and an infection, which requires 6 months of antibiotics. When she came to us, she requested not to have surgery because what she had previously. So, and this basically, it's a right radial axis angiogram showing this severe calcified lesion in the common femoral. We IVIS, as you can see, 360 calcium. This is a case where, if I want a balloon and end up with a dissection, even though there's some European studies showing, certain stent in common femoral may be an option, in the US, we still try to avoid putting stent there. So you really need to modify this calcium, and in this situation, we did the orbital atherectomy with a 2.0 burr via radial, the same burr you use for the transfemoral, which is a shorter lady. I went up with a DCB, and this is the final result. And this is the IVIS images post. So you see nice expansion, and you do not require any stenting. Make it a little bit more complicated. To show the possibility we have, but it's not a talk about radial to peripheral. This is a talk about certain cases where really femoral access is not an option. So 75-year-old male, severe PAD, has a known left-sided external iliac and a common iliac occlusion, has a fem-fem bypass 10 years ago that failed, had another surgery. So 2 surgeries of fem-fem, and this one is open. And he started having a life-limiting claudication on the opposite direction, so on the right side. We tried medical therapy and everything else, but it did not work. You see the right ABI is 0.4. CTA showed what we know, the left side common iliac and an external iliac is occluded, but now it's telling us that the common femoral on the right side, or the ostial SFA, is severely stenotic. So, access-wise, you can't do contralateral up and over. You're really 2 options here, either pedal or you can go radial. With the pedal, you lose the option of getting good images because you're coming against the flow. So we did a transradial access. You can see the picture here, very, very tight lesion or even occlusion and getting filled with collaterals. Wiring this, so we used a 119 centimeter radial to peripheral sheath, wire escalation. We were able to get a 018 wire, but nothing passed. So I had to use a 2.0 balloon just to get something through. We switched to the Viper wire, 475. And again, now we're talking radial, we're talking about 400, 475, 450. It's pretty long, but we have long tables, so that works. So we end up doing orbital atherectomy. So the reason I'm showing this case, not only just because this is possible, but you're gonna have to be careful because you really don't want to do orbital atherectomy with the takeoff of that fem-fem bypass. What if you injure it, right? Nothing worse than your surgical colleague do a beautiful job with a fem-fem or a bypass and you ruin it, right? You're here to help the patient. So we end up actually, we ballooned, we crossed it, we did the orbital atherectomy backward from distal to proximal. And that's the beauty of this device. You don't have to, treat only forward. You can only treat forward and you can treat backward. And we achieved orbital atherectomy. This is, just post atherectomy. We did a balloon angioplasty, we did IVIS, and we did a balloon angioplasty, and then we did a DCB. And we'll show you the pre-picture and the post picture. And now you have nice profunda, no distal embolization, and the gradient was 5 millimeter. Another case, what about multi-level cases? Can we do that? This is an 85-year-old male, ischemic cardiomyopathy, EF 25%, previous CABG, has a PAD and previous SFA stent. Came with Rutherford classification 4 and a CTA showing a left common femoral of a 90% and a distal SFA also 90%. So if you look at the angiogram, you can see just a hint of the profunda coming out. The common femoral is severely stenotic. You see the stent is patent, but at the popliteal also you see this nodule calcium. To me, where I see, and I would love to hear the panel as well, when to choose different atherectomy devices, especially now with the IVL, being more and more company coming with IVL, when would I choose atherectomy IVL or just IVL directly? For me, whenever I see nodules, I prefer to do some kind of atherectomy. And in this case, we did a 1.75 on a 180 shaft, radial to peripheral orbital atherectomy. We passed a couple of times in the common femoral, and also when we pushed it all the way to the distal part, we did not birth through the stent. The stent was patent, but then after we delivered to the popliteal, we perform also some orbital atherectomy, and this is just post atherectomy alone. Then for the common femoral, which we delivered 8x60 M5+, even though they say it's 7 French, but it can go through the 6 French sheet. And we delivered a DCB there and a DCB of the popliteal, and that's our final result. The gradient across that common femoral was 10 millimeter of mercury. We left it alone. So what about possible complication? And I think that's, again, important. Whenever we try to do more, we need to make sure you're ready for complication and what you do in this situation. For our radial to peripheral cases, we do a lot of vasodilator just to make sure the distal segments are well expanded. But still, distal embolization is a problem. Dissection can happen, and of course, perforation. This is a case to show one of the complications we had with a 77-year-old female had a claudication. Her left side ABI is very abnormal. And she comes in, and you see this really discrete nodular proximal SFA. This is actually a transfemoral case. And distally, you see 3-vessel runoff, with PT being the more prominent one. And so the IVs there. So option for treatment is PTA without stenting, orbital atherectomy, directional atherectomy, or IVL. I think either option may be a reasonable option, except number one. I think if you just try to do PTA, you may end up with a perforation or a dissection. Now with other technology, maybe all can be available. So figuring out with the Compliance 360 trial, I want to try to avoid stenting. And I said, let's do orbital atherectomy. So we achieved with a 2.0 solid burr. Beautiful result just with the atherectomy. 2 seconds later, the patient is screaming of pain. Her foot is hurting, it's painful. Now we did something, we need to know what it is. And when you look at below the knee, all of a sudden that PT that was dominant, now it's gone. Even though AT is open, even though the perineal is open, but she is a PT dominant patient. So we end up, this is just to show you before and after. And so there's a distal embolization. And what we ended up doing is we actually went in with the Penumbra bolt with 7, and this is the small plaque that we had to take out, and the pain went away. Just for R2P, I think the discussion was done previously about R2P. I don't want to bother you with this as well, but I'm very passionate about it. I think now, every time I give talk about R2P or radial to peripheral, I'm adding to the slides. I'm adding more products because all the companies now are understanding that this is something maybe be the future. So we have multiple DCB, that's 200 shaft. We have wires now that all 014, 018, and 035. We have 2 atherectomies that can work, and other, just as an example. So orbital atherectomy can be used in radial or femoral. It's for dense, heavily calcified vessels. It's not recommended for in-stent or non-calcified lesion. Adjunctive therapy like IVL or serration balloon or scoring balloon might be needed. And a recommendation based on the trial is to have at least 2 passes per speed. Thank you.
Sameh, that was a terrific presentation. So I just want to quickly ask the panel, when they use orbital atherectomy, in what percentage of cases are you considering or feeling that there's a need for some type of distal embolic protection? So I'm just going to go down the line. Maybe I'll start with Tony.
We used to use, I mean, we were published that Pathfinder and the Orbital 360 trial. We used it a lot in the tibials. I mean, before there was other things, rotablator was not as useful there. We used it all the time. And we rarely used embolic protection in those cases. I will tell you the one place I would not use it, or if I did use it, I would definitely use distal embolic protection, is in-stent. Orbital atherectomy to me is not the right in-stent therapy, but heavily calcified tibial vessels all day long and all the way through the pedal arch. I'm very comfortable with it in those places.
Not much, to be honest. Because there are no ready-made filters for it. You have to use a NAV6 or something else. So I actually don't.
I tend to use it for all forms, just because I'm a little bit more paranoid. For orbital? Yes.
Yeah, I used to use it a lot, but now to me, if I have a single vessel runoff, I would use it just because, do not want to make the case 2 more hours.
I do also use it 100% of the time for orbital, directional, any laser, any form of thrombectomy. I guess I am also very paranoid. I've seen all of them embolize. I even see IVL embolize.
Yeah, our next speaker is going to talk about IVL, but obviously for calcium vessel prep, orbital atherectomy and IVL, I think, are probably what we all, reach for. So after Zach gives his talk, I'm going to ask the panel about combination therapy and, when and in what circumstances. And I did want to ask Jane, though, as a surgeon, obviously you do a lot of common femoral endarterectomy, and more people have been using orbital atherectomy, especially in conjunction with IVL for common femoral disease. And I know probably opening up a can of worms here, but what patients would you consider doing endovascular with, say, orbital and/or IVL for common femoral disease versus just proceeding with an endarterectomy?
No, I think that's a good point, because endart is fairly well tolerated, and most people are going to be surgical candidates for it. But are they going to heal from it? Would they benefit from it? I think your second case actually highlighted that very well, with someone who was a little bit sicker, had a lot of medical comorbidities, and obviously her recovery is going to be a lot easier with an endovascular approach. So I think it's really patient-centered. If it's someone that is not going to tolerate an incision very well and heal from that and take care of that wound, then I think endovascular is a very reasonable approach.
I love it because I have some common femoral stuff in the next talk.
So let me invite Dr. Drew Klein to talk about specialty balloons. Drew, you have been called on the stage when you were not expecting it.
Sure.
But I'm sure you'll do a stellar job. We're eager to hear from you, and drag it as long as you can till the slides get uploaded. I'm kidding.
I'll tell some jokes. We'll see what we're doing here. All right, well, I didn't expect that quickly. So can you pull up my slides? Thanks. I just uploaded mine. I can see it. All right, as long as you guys can see it. Hi, I'm Drew Klein, one of the interventional cardiologists at Piedmont, Atlanta, and I get to talk about balloons and what's so special about them anyway. So I got kind of a interesting talk. So I asked Subhash, what do you want? He said, I want a case, I want to know why you're using something, and I want to know some data points, and then some technical tips. And while for a balloon, don't try to blow it up with your mouth. You actually need an insufflator. That's my only technical tip. That's it. If you can't blow up a balloon, you shouldn't be doing this. All right, so here's a case of a usual critical limb ischemia patient. All of us see this every day, included, I think, almost Tony's case exactly. TPT trunk occlusion, AT occlusion, reconstitution of the PT a little bit down, and we were able to cross this, and eventually what I like to cross with a wire and then use a nanocross balloon, and then I used a chocolate balloon, 3.0 chocolate under IVUS guidance, and then eventually ended up stenting the TPT trunk, used it also the chocolate balloon on the perineal with a good result, and that was it for this part. And then as I was backing out and I noticed this on the way in, I found this lesion in the SFA, and you can argue, should you leave it alone? It's inflow. Is it obstructive? Is it not obstructive? Do you want to put a flow wire down? Do you just want to leave it? And I chose to use it, again, I used the chocolate balloon here after I did IVUS because it actually was markedly more obstructive on IVUS than it looks angiographically, underscoring that I think We would not do this in the coronaries without IVUS. I mean, how many people are using IVUS 100% of the time for coronary work? How about 70% of the time? 50? All right, so I don't do any coronary work without IVUS now because I think you miss it, and there will come a day where I think it will be 100% peripheral. I'm going to predict that because you start seeing stuff that you otherwise would leave alone, and we already know we have some outcomes that we can improve upon. At the end of the day, I used the 6.0 chocolate balloon and walked away. I did not use the DCB. I felt at that point I'd used enough money. I was trying to be a fiscal steward, so I used chocolate instead of DCB. You can argue with me which one's more cost effective. But at the end of the day, I think when we talk about when to balloon only, we know that focal lesions do really well with balloons, right? We know from the Dutch iliac stent trial that balloon angioplasty in the iliacs did fine at 5 years for task A and task B lesions. When you want to avoid stents, when you have a long lesion too, if the whole AT or the whole PT or the perineal is there, you really don't want to line that with a bunch of DES right now. If you're at a graft anastomosis, I think we're going to show some data here. There's actual data about graft anastomosis. And then as for your choice of balloons, well, there are a couple things out there. Some of these balloons I'd never even heard of. So thank you for the opportunity to give this talk because I did not know about the EXO KISS balloon or whatever you want to call it, and the Serenader and something called Ultra Score. So maybe I'll be introducing this to you as well. So here's the data that he wanted, which was cutting balloon. So I don't know how many people are still using cutting balloons in the coronaries. We do have a trial going on, shortcut, but in the peripheral, there is some data, about 128 patients up there looking at very high success rates, again, in task A and task B lesions. Technical success rates extremely high, and complication rates in this study, which was much, much older, actually was much higher than I would have expected, but the patency rates looked pretty good. Limb salvage, 84% in claudicants, 77% in CLI, and survival was overall pretty good, I have to say, for that patient population, especially the CLTI population. So there actually is data for that, and there's actually data for using cutting balloon on a graft anastomosis. I would not do this on a fresh graft. I think the surgeons would agree. You don't want to be using this. I've actually seen a cutting balloon in a saphenous vein graft rupture it, so don't do that. Retrospective study of 115. Basically, here's your freedom from reintervention. It's not great, but it's better than nothing. 1 year, 54%, and freedom from graft occlusion, almost 80% at 1 year. So there is some, and I think it really comes down to mismatch, right? You're going from perhaps an autologous vein, or you're going from a graft into a native vessel. So I think it's important that you can use a cutting balloon there. So angiosculpt, I just like the registry. It's called Panther. I just think that was cool. 101 patients. Again, data there here with 124 calcified femoral popliteal lesions. They actually did a study where scoring balloon or angiosculpt versus plus DCB or stenting. A 12-month patency rate was 81%, and there was actually no difference between any of the arms. So it didn't matter what you did. Patients did not bad, 80%, 83%. I think that's pretty good considering, but I found it interesting and didn't really matter what you did. How about real life? So you go from studies into real life, and we all know that what happens when people go to real life, things change. This was 425 patients that basically got no difference between angiosculpt and standard PTA plus or minus stenting. Survival rates, amputation rates, or need for revascularization. Here's another balloon. I don't know how many of you know this. It's an ultra score focused force. You must focus down your son. This is an interesting balloon because it's made by Bard, and I put the companies up here in case you are interested in it because I didn't know who made these. 106 patients with femoral popliteal. This was the interim results. Mean lesion length was actually pretty long, so not really task A lesions. 126 millimeters long. Most were 55% were moderately or severely calcified, and a pretty good reduction with 100% technical success rate. And provisional stenting is what we're all trying to get away from, right? It's about only 7%. So this might be a valuable option as well. And the Serenader balloon, which basically looks like a saw when you look at it. This has been studied in a whopping 25 patients. in the FP segment and 46 patients in the below the knee segment. Again, not bad. Everything works as long as you cut the plaque. Remember, the idea behind all these specialty balloons is that you got to score the plaque so you don't cause dissections, and you can use lower pressure. So that is the principle of all specialty balloons across the board. So you're really trying to limit dissections and limit stenting. So here's one. How many have heard of this? Am I just out to lunch? Exo, score? Okay, I'd never heard of this before. This is some sort of exoskeleton that you can put on any over-the-wire, on any balloon. It's basically like a guide liner that makes your balloon into a cutting balloon. And it's a metallic exoskeleton of 22 struts that basically slides on, as you see in the diagram, and basically allows you to change your balloons. You can use any off-the-shelf balloons, and this thing slides on and off. I don't know how many times you can use it, but if Transic Scientific is here, go check it out. So I had to do some manipulation of the chocolate. The chocolate balloon, as you know, I like it. This is Jihad Mustafa being Willy Wonka up here with the chocolate registry. This was 262 patients with almost 300 femoral popliteal lesions. Pretty good success rate using the chocolate balloon, right? These are the pillows of air. I honestly used to think this was BS when it came out. And then I started using it, and I said, no, actually this works. Procedural success rate, about 85%. Bailout stenting, only 1.6% in this registry. And pretty good TLR and all-cause mortality at 1 year. With a core patency, a core adjudicated lab of 64% patency at 1 year. I just think Jihad looks good as Willy Wonka, but not as good as somebody else coming up. There was a single study, 84 patients with chocolate balloon plus DCB. So what if you did the best of both worlds? For those of you who are Van Halen fans, that's the album out there. Chocolate plus DCB, I think that's what most of us would be doing. Mean follow-up, only 12 months, but almost 98% freedom from TLR. And our own Mehdi Shishkabur is Willy Wonka. His face fit perfectly on this. I just couldn't resist. So this is the chocolate touch study. I don't know if anyone knew about this. This is basically a paclitaxel chocolate balloon with Lutonix DCB fused together. So that is the chocolate touch, and you can't touch this. You can't touch Mehdi. He's amazing. 313 patients randomized, primary efficacy rate pretty decent there at 80%, and it was non-inferior and had superior efficacy. If you want to know about statistics, ask Mehdi. Primary patency almost 80% and 94% freedom from TLR. So pretty decent results here using chocolate touch. I personally would have used a different drug-coated balloon, but I didn't come up with a study. All right, so how about head-to-head trial? For any of you who have kids, who know the books, who would win? Are there any data out there existing between specialty balloons? I can hear Chris White yelling at me, going, all you're doing is driving up the administrator's costs, and you're doing nothing. There is actually one study looking at cutting balloon versus high-pressure balloon for AV fistula stenosis. This actually showed a benefit of almost 300 patients. It's 3 studies, and actually showed a benefit of cutting balloon angioplasty. Other than that, there's not a single shred of data out there looking at head-to-head, and nor do I anticipate there will be any. So choose your own adventure. Those were my favorite books going up. And remember, better is the enemy of good. So PTA works for certain lesions. Short lesions do really, really well with balloons. If you want to walk away and just not have to stent, they work really well. Calcified lesions also work really well with cutting balloons, also chocolate, also any of the ones that I showed. Anastomotic lesions, if there's a big vessel mismatch, I think sometimes the balloons work well. Below the knee on the CLI case that I showed, those do really well with long pressure. I do 5-minute inflations routinely, 3 to 5 minutes for below the knee. And with nitro, and again, intravascular ultrasound guidance for below the knee 100% of the time. As per which one you want, choose whatever you want. I think it's at the end of the day, it's whatever your favorite. On my shelf, we have chocolate balloons and we have cutting balloons, and those are the 2 that we use, in addition to, of course, IVL and the standard stuff. And with that, I'll say thank you very much for the opportunity. Hopefully I delayed enough to get my other speakers up here. Zach's back. All right.
So Drew, a few questions. You named a few balloons that I, to be honest, have never heard of.
That makes 2 of us.
Oh, I see. So it was new to you when you were using it. Is there anyone in the room who actually has seen or used the scaffold to
Does
slide
anyone
it
use
over a
XO
balloon?
Score? By the way, when you go to the website, you can't do it from your hospital because it says XO Score, and I think they think you're up to some nefarious activities when it says XO Score. So I could not get on it on my hospital website. Just FYI.
Okay, that's useful information.
Yeah.
I want to
Don't
make,
Google that, by the way. You might be surprised.
So I want to ask you, you said, what is your favorite tool amongst these specialty balloons, and which one is your go-to device on an everyday basis?
So outside of the tapered nanocross balloons, which I love for the tibials because you can do I run out of them all the time, 3 to 2.5 tapered, it's got to be the chocolate balloon. I again, when it came out in the chocolate registry, I was very naysayer-esque, and then I started using it, and I have to say that is my go-to balloon for when I don't want to, in fact, I was really pissed when they took it off the coronary realm because I couldn't get it now. When I don't want to stent, that's my go-to one.
Let me ask my colleagues, starting from left to right, have the specialty balloons replaced, in most cases, your regular conventional angioplasty balloon, or just briefly, your best case scenario for using it?
So it hasn't completely supplanted my conventional PTA. To be honest, PTAs are still cheaper for a hospital system perspective, right? Chocolate balloons.
He didn't ask me that though. He said if I had to choose one, I actually use the PTA first.
I do like chocolate balloon because it prevents that dog boning effect, so it minimizes the amount of dissection that you get. Like you, if I'm trying to avoid doing a drug-eluting stent or or a bowel resorbable scaffold, then I would reach for chocolate.
Sayfo?
So I've been impressed with the serration technology. If you look at the serration technology comparing to, like, for example, a cutting balloon, at the point of contact, the endoscope has 24 times the power, where the serration has 1,000 times. So and they have from, I think, like 2.0 SLR all the way to 6. So I've been for below the knee, especially there's a small study where Dr. Vinisa Chandra showed, for the recoil study, and compared PTA below the knee for serration balloon, and there was a significant less risk coiling. So I think the comment that I want to make is, even if you're using a PTA, it's that the art of using balloon angioplasty has been lost in the coronary and in the peripheral. And I think that's why PTA doesn't work. If you go up for 14, down quickly, give it 10 seconds, you create dissection. But if you do it, as you said, 5 minutes, it's a longer balloon, you just go slowly on the balloon, I think PTA works very well in a lot of cases.
Jane, for you?
I use the angioscope or chocolate mostly for the graft stenosis, like you were saying, for long-term graft patency, because the intimal hyperplasia is just so robust there, and it's really good for treating those lesions. But in normal vessels, probably just for calcitrant lesions, kind of very selective use.
Yeah, it's good to learn. I have to change my practice because I don't use it as much. Peter?
Yeah, I unfortunately didn't have as robust experience with chocolate. So in our lab, we use the Serenator. I've been really impressed with it. The things that I like about it, it comes in 40 and 120 millimeter length, so it can be efficient. So in cases where you don't want to put a stent in and it's not quite calcified so badly that you feel like you need to pull a more expensive IVL balloon, I think it really works very nicely there. Usually follow it up with a DCB and usually get a very nice acute as well as a long-term result.
Tony, your choice?
Yeah, I had a lot of experience with chocolate. When it first came out, we did many cases and in the trials as well. So I was, like you, very impressed with it. We've kind of moved to Serenator a little bit more. I will tell you, though, that calcified tibial lesions, really, the issue with some of these balloons is their maximum burst pressure is 12 atmospheres, so you really can't get really big. So with chocolate, what we learned in the trials is that you had to oversize those balloons to be able to get the results you were trying to get. And fibrotic lesions actually do quite well with these. Calcified lesions, not as much. So if I've got a long segment fibrotic thing, I'd probably use Serenator today, whereas 5 years ago, I probably would have used chocolate.
Thank you, Drew.
Thank
that
you.
was very enlightening. Thank you so much. Let me invite my dear colleague and friend, Dr. Rosol. I always say when I introduce him that he needs a pair of dark shades because his future is going to be extremely bright looking ahead. Not put you under pressure, but,
Yeah, no pressure at all.
but you are an amazing operator. I see him every day at work, so I think I'm very, very impressed and a very talented young man.
That is a huge compliment coming from you, and I appreciate it. I just show up and I get to work with my wife.
I even said
every
it
day.
to his wife.
Yes, that's what the cath lab. I see some of our cath lab staff here too, so they have to put up with us when we double scrub. They see us coming and like, nope, you're not allowed in that room right now. We need to keep the day moving. But no, we love to double scrub, and it's great. We learn from each other. So I've been tasked with talking about intravascular lithotripsy, so we'll get started here. No relevant disclosures. So I love that we're talking about common femoral stuff because I'm going to talk about multi-level disease here too and how I've used lithotripsy in that regard. So this is a 72-year-old Indian American gentleman that we took care of recently. He presented with really accelerating angina over about 2 months and to the point where he had rest pain and has dependent rubor in clinic. His ABI was 0.15 and he had a duplex ultrasound that showed severe distal common femoral disease and an SFA occlusion. You can see his past medical history here. He is still, despite all this, actively smoking cigarettes. Here is his angiogram. These are just still shots. We'll show you runs later on, but you can appreciate the multi-level disease here. Distal common femoral disease that's encroaching on the profunda, heavily calcified mid-SFA, poor runoff as well. Okay? So what did I do? Well, we stopped. I took this gentleman off the table, and the clinical challenges, I've got someone that's got severe calcific multi-level disease who's actively smoking. And the other important thing to note for him, when he was in his 30s, he had some type of, I believe it was osteosarcoma, but he doesn't remember the exact type of cancer. And I'll go back here. If you look at his distal femur there, he had significant radiation therapy to the entirety of his leg. Most concentrated around the knee, but he also did have it up at the hip level too. So, how do we approach this? I took him off the table to have a conversation with our surgical colleagues. I'm gonna ask the panel here. I don't have an open wound, but I do have rest pain with multi-level disease and an active tobacco user. So are we gonna go and try to make a path all the way down to the foot? Are we just gonna try to get him out of rest pain? What's your guys' approach?
What did the skin look like, and did he have vein?
He did not. He had a vein that was felt to be adequate. It was about a 3 or 4 millimeter vein. And he's a very thin gentleman. And to your point, his skin turgor on the left was significantly different than the skin turgor on the right groin.
Yeah, I think we see this with carotids a lot too. With radiation therapy, that skin loses a lot of its elasticity, and the wound healing is so terrible that even if you can do it, you can do the bypass, you've created wounds now that are not going to heal. So I would be very hesitant to jump to bypass.
Can you go back to the last picture? If you went a bit of bypass, what would you land it?
Yeah, great question.
Yeah, there's not much of a runoff here. Looks like there's a PT
TP
at the
trunk is
foot.
occluded, the AT occludes in the mid, and really his only good vessel into the foot is his PT, which doesn't reconstitute until 8-10 centimeters above the ankle.
Yeah.
And the other thing is this patient, I mean, even if you take him off the table, to me is, if he progressed that fast, I would be worried about sending him home and get him scheduled in a few weeks. I would just keep him in and make that decision and just bring him back as an inpatient, because you may end up with a wound and then the whole process change.
All great points. And that's exactly what we did. After we did the angiogram, we admitted him to the hospital. We kept him on a heparin drip, and I discussed with our vascular surgery colleagues. And the conversation was the same, and I'm glad that you raised those points. There was a large concern about his ability to heal or creating a non-healing infection and wound in his groin, even if you got him out of the rest pain. Our thought was because he didn't have open wounds, that we didn't need to have inline flow all the way down to the foot at this point in time. And the goal was to get him out of rest pain and then let him proceed. So what we did is we brought him back to the lab. And my goal was to at least treat the common femoral. And if I got through the SFA to better feed the geniculate collaterals, great. But I was not going to go, at least on this initial endeavor, all the way down to the foot. So, really important here too, obviously, was to to do what we could to preserve his profunda. I think different than the case that you showed, Sammy, this common femoral was a little more distal and starts to encroach on the profunda. And we did IVUS it. I'm sorry I didn't include some of these IVUS images, but this is a large circumferential with a nodular component of the calcium that is on the wall that is most proximal to the profunda. So that definitely influenced our device selection here as we tried to treat this. So here's what we have, okay? Never look a gift horse in the mouth. We take our wire down, and I had a nice little loop, and we noticed it was past where that SFA occlusion was. So there's definitely a thrombotic component to that, and our wire was able to cross easily. So once we had a wire across that, we just, I was gonna move forward and treat both the SFA and the common femoral. Very calcified lesion. We used an E8 lithotripsy balloon here after we did IVUS, and that was the appropriate size. We gave all 400 pulses, and we still had some residual stenosis, and so the common femoral was a 7mm vessel, so we went back with a 7mm E8, or M5, excuse me, and I actually brought that down into the SFA as well. And I think it's a good reminder, and as I'll show you in a slide or two here, you have to oversize with this balloon because you want the balloon to touch the walls in order to deliver the therapy. So undersizing this balloon is not the way to go. It's a low pressure, your chance of dissections are low. It's not that it doesn't happen, but you want to appropriately deliver the therapy. So this was the result we achieved after we did a DCB. Is it perfect? No. But without him having good outflow, I decided not to put a scaffold here. Here's his common femoral after all 310 pulses with the E8. And we used a drug-coated balloon, and this is our final result. You can see in this picture too, the benefit of using lithotripsy is you can protect the side branches. So I did intentionally place a wire down the profunda while we were treating in case we did have a flow-limiting dissection. Here's his pre and his post ABIs. He had a toe pressure of 0 initially. His ABI was 0.15. It has now increased to 0.5, and we have a toe pressure of around 30. Okay, so is it perfect? No. But did we heal, or did we improve his rest pain? Yes, and he's now back to walking. I saw him in clinic a few weeks ago. He's down to 3 cigarettes a day, he tells me. Yeah.
Hey, Zach, quick question.
Yeah.
You had mentioned that you had done IVUS. I'm just curious, what was the common femoral by IVUS? I got to be honest with you, I might have been tempted to use an 8L6 there for the CFA.
Yeah, it was like 6.7-ish, and so I felt in the spirit of I was going to get apposition without dissecting. That's why I chose the 7. He's a very petite gentleman. He's like 5'4". He weighs 130 pounds, dripping wet, and so but the importance is choose the appropriate size where you're going to get apposition, and I think your point's well taken. You want to make sure you oppose even as the vessel continues to grow. And so that's why, even though I knew it was a 5mm vessel in the SFA, if I back up a slide or two, that's why I still took that 7mm balloon down there to give additional pulses, because I knew we can inflate at 2 atmospheres and we still have apposition, and you're going to have a delivery of the therapy. So some important points to just to use with a lithotripsy we've talked about. Oversize, okay, because you need that to oppose. Move the emitters around as well between inflations. So that's pulling back and advancing a few millimeters. With the E8, not as important, but if you are using an M5, remember that middle emitter is actually stronger, and so you want to concentrate that on where your highest level of calcific disease is. But the closer you bring these emitters, the goal is to create a whole bunch of microfractures to improve vessel compliance, okay? If you're doing the common femoral interventions, especially as it gets to the distal bifurcation, make sure you're protecting the profunda, because that's the workhorse of the leg. I think that's all my slides.
Thank you, Zach.
May I ask a question?
I just want to emphasize for the students that the point to preserve the profunda was made repeatedly, because that can be the Achilles heel of a common femoral artery intervention that is endovascular. And most of us always think twice before doing it, because surgical endarterectomy is a more durable option. Of course, Jane articulated why in this particular case it was not a great thing. So the straight artery that goes down from the common femoral is the superficial femoral artery. The one that goes on the side is the profunda femoral, just for orientation. And so that profunda femoral is the main supplier of thigh muscles, and of course provides collaterals to the below the knee arteries if the superficial femoral artery gets occluded. So I think that's the reason that Zach was careful enough to not extend a dissection or a flap into the profunda femoral artery that would jeopardize the patient's durability. And that was also the reason why a surgical opinion was sought in this case. I just want to articulate that, Zach. That's actually a good point, because we don't want to land into this debate of common femoral artery. I want to ask, again, I learned so much from June today. June, in this particular case, would OCT be a better imaging tool in your opinion, or it is too proximal for you to use, or if it is diseased, it can still work?
So I think the traditional OCT might be a little bit difficult here. I myself actually learned the technique for imaging common femoral and SFA from Sahil Parikh. So what we do is you park your catheter or your sheath right above your lesion, and then you can actually do proximal occlusion by hand. And that would minimize the amount of washout, but it will be difficult. As I said earlier, about 6 millimeters or so is kind of the upper cutoff of how you can image. So beyond kind of a 6 millimeter area, you're not gonna really see the wall.
And to segue into your next talk, Zach, thank you very much. I'll invite June here to, and of course, I'll have Peter introduce, but my question is, would you have chosen an alternative atherectomy tool in this situation and use it as maybe as a segue to your next talk?
I was actually thinking how I would have treated the case as you were presenting. And I oftentimes use the SFA CTO as a natural filter. And then I put a embolic production into the profunda. And I would have probably considered CSI potentially in this napkin ring calcium.
Would anybody have used directional atherectomy since there was a significant nodule there?
So my favorite part of your case, Zach, is to congratulate you for having a clear-cut mission about what you're going to accomplish before you started. I think you can get very easily enticed into trying to treat everything at once, and that generally leads to bigger issues than you need. And in this case, there was not a wound. So to be able to go into this and say, okay, I'm going to treat the common femoral, I'm probably going to treat the SFA, and unless I have a real problem, that's where I'm going to stop, because you know you're going to get in and out, and you did a really nice job of that. So I congratulate you for having a clear thought process, because I think that peripheral cases actually do require that you have plan A, B, and C if there is an issue, but this was one where plan A was the plan, and it continued to be the plan, and it never veered from that. And that's not typical of coronary interventionalists and others that try to make everything in every case look perfectly. So that was a really good job of that.
Yeah, I think that's an important point too, because as we discussed with our, when I was talking with our vascular surgery colleagues, as we were looking at the case, he asked, well, what would you do, or what do we want to do? And my answer to him was, we just need to get him out of rest pain. So from a surgical perspective, the only plan was going to be to do a common femoral endarterectomy if that was possible, because we didn't feel there was adequate runoff for a bypass with all the radiation. But as we looked, as they examined him and looked at his skin turgor and everything, I'm glad you brought up that point, because that was the exact concern from a vascular surgery perspective.
Before we bring June up, I want to take advantage of the fact that on our panel here, we have a very strong presence from Baylor Scott White, and who are the leading site right now in a different intravascular lithotripsy platform, which is being investigated clinically from Amplitude Vascular Systems. It's a Power PAD2 study. And so this device is a little bit different from the shockwave device in that instead of using sonic waves, it's using CO2 to create hydraulic waves. And as you know, with the E8 device, you can get 400 pulses. With this newer device, you literally can get 5,000 pulses, and it's 15 pulses per second versus 2. And I have to say, in the cases that we've done, and this is really what I want to ask the panel, my impression is that it seems to be particularly effective for eccentric lesions, and it works incredibly fast. Literally within seconds, the waste on the balloon is gone. So I wanted to ask our friends from Plano what their experience has been with that particular device, and do you feel that it perhaps may have something to add above and beyond sonic lithotripsy?
Sameh, you want to start?
Sure. Yeah. So we're honored to be part of this trial and other trials also. I think the field of IVL is growing. There's other technology with laser base and different kind of electric, and so we're part of the study. And it's fascinating. You know, when you put the device at the lesion. What we used to from shockwave IVL is you inflate the balloon, and then you can see the dog boning, and then you slowly open up. What we're seeing here is, it's literally, as you said, it's like the moment we turn it on, it's so powerful, the whole thing pop. And you always worry like, oh, I dissected because did I just deliver so much energy so quickly? Again, we can't show the result, but we've been impressed with the results so far. I think we've enrolled 10 patients, right, Tony?
Yeah, we've enrolled 10 patients. I think the thing that is, you know, it's almost, it's uncomfortable to watch how fast the device goes up. But the thing is that within seconds, it has actually accomplished what you take, you know, long periods of time with our current IVL device. So I think that there's probably going to be some real advantages to it.
But I want to also point out, you know, we need to also remember those are IDE trials. There's selection bias maybe to it because you're selecting certain cases. It will be very exciting when all this other technology come to the market and we're able to really commercially in real life head-to-head compare, because I think now sometimes in an unfair way, shockwave devices are being introduced to cases when you talk to experts like, no, I would do atherectomy first. This case should not be just IVL, and in real life I would do CSI, I would do laser, I would do HAWK before we go in. But it's very exciting to see the technology, because IVL was one company for a long time, and now we have different technology under IVL.
Yeah, for whatever it's worth, we have, of the 8 cases that we've enrolled, we've IVUSed every single one. And I had the same uncomfortable feeling the first couple cases I did. It's like, boom, within 3 seconds, the lesion was gone. And you think, oh, God, it's got to be like a grenade went off in there. But in point of fact, there were not significant dissections. And we placed the stent in only 1 out of the 8 cases that we've done. And to date, the stent rate has been about 10%, but some of those were Chris's cases where he just loves putting in superas, and he put them in anyway, but they weren't because of a need for a bailout. So it'll be interesting with, you know, with Bolt now coming into the fore and FastWave's going to be following, and then of course the Abbott device after that. So it's going to become a pretty crowded field. All right, let's move on, and I'll ask June Lee to come up and talk about directional atherectomy. June, of course, superstar from Harrington Hospitals in Cleveland. June.
Right, that should be on. These are my disclosures. I have 2 cases. The first one's potentially a little bit controversial, so do not throw any tomatoes at me today, thank you. 61-year-old woman. She has severe bilateral upper extremity claudication, right arm worse than the left arm, dyslipidemia, hypertension, and a history of arteritis. She initially was seen by rheumatology like a year or 2 ago when she was first found to have arteritis. There was a differential of giant cell versus Takayasu. She did undergo a temporal artery biopsy, and that was negative. She underwent steroid therapy, her ESR and her CRP levels normalized. However, she had persistent bilateral upper extremity symptoms. Her LDL of note is 148. Apparently, she is intolerant to every statin we've tried, resistant, did not want to try PCSK9. She has a list of about 10 allergies. Finally, did agree to using Zetia. Her Lp(a) was negative. She was referred from rheumatology and from one of my vascular surgery colleagues for evaluation of her upper extremities. Here you can see on her bilateral upper extremity ABI and digital brachial index, that the right side has, there's a typo here, the right side digital index is 0.8. The left side is actually not as bad, hence her symptoms are actually worse on the right upper extremity than the left. And you can appreciate on the PVRs that there's actually very blunted waveforms in the wrist as well as in the digits. Any comments from the panel so far?
No, this is very exciting.
All right. So, CAT scan was performed. So primarily what you want to look for here is essentially thickening of the aorta, suggesting of other sources of arteritis, vasculitis, sorry. And I didn't really truly appreciate any thickening of the aorta. I did also perform a upper extremity CT scan, and unfortunately, they did the contrast bolus through the right upper extremity, so the bolus itself actually completely contaminates my image of the right upper extremity. There's a slight pause right where you can see the chronic occlusion right here on the left upper extremity of the left axillary artery. Took her to the cath lab after much discussion. Obviously, we are very conscientious of performing upper extremity interventions. Losing a finger is much more impactful on a patient's quality of life compared to losing a toe. So we have to be very vigilant about patient selection and how we do these upper extremity interventions and/or angiograms. Interestingly enough, this is right around, this is towards the end of November when I saw her in clinic. She told me she really needed to make Christmas cookies. This is what she does with her family every single year. And she said because of the upper extremity claudication, she could not make Christmas cookies with her granddaughters this year. So she begged that we do this procedure before Christmas. So this is in the beginning of December in 2024. You can see here there's actually an occlusion. I'm going to use this laser. Occlusion right here. My sheath is actually parked in the subclavian. This is the right internal mammary artery coming down here. And then there's some stenosis proximally, and then an occlusion here in the axillary artery. Comments from the panel? How will you tackle this?
I am lost for words. This is
So, can anybody explain why the left, I assume the left has the same problem, has better digit flow compared to this? Just collaterals on the left?
Yeah, I
better?
think there's a shorter occlusion on the left side, and the collaterals are actually feeding. That's why you see the digital pressure of 0.8 even on the right side, and essentially normal on the left
And
side.
in upper extremity cases, which we do like 1,000 a year, I'm joking, I'm completely joking. Do you do the same runoff for the arm and fingers and?
You do, actually. Good question.
June, is she right or left-handed?
She's right-handed. Yeah.
Do you have
So-
pictures of it proximally, like the great vessel takeoff?
I did not. I didn't do an aortogram because there was already a CAT scan, and it showed that all of the origins of the great vessels were patent. Good question. So yes, you do actually want to take a distal runoff. Here, after we've traversed it, actually, this was with a command wire and an 018 catheter as well. We do a selective injection, and actually, it's exactly kind of like the tibial arteries. There's a trifurcation, there's an interosseous vessel that's kind of equivalent to the peroneal artery. There's a radial and an ulnar artery. But in her, she has significant vasospasm. You can see in the right panel, the hand is completely blanched. And this is after I gave her so much vasodilation. Calcium channel blockers tend to burn a lot here. Adenosine tends to burn. So my typical go-to in the arm is actually nitroprusside. In patients that cannot tolerate nitroprusside because of blood pressure, then I do nitroglycerin, kind of at lower doses. But I usually slam them with a ton of vasodilators, essentially to open up the fingers. That's a good question. You know, as I was making this deck, I was thinking maybe I should have warmed the hand so that it looked better for this presentation.
Is she a smoker or no?
No, she's not a smoker. She's not a smoker. But she probably has Raynaud's, hence why it looks so bad on the cath lab table. I did IVUS. I'm not a one-trick pony, so I did IVUS. This is a pullback from the distal segment towards the more proximal segment. I was honestly curious as to whether or not this is still her arteritis, or is it pure atherosclerotic disease? I will say I don't think we can tell from IVUS because it just looks like heterogeneous plaque.
There is one theoretical differentiation in imaging. Arteritis does not cause or inhibits positive remodeling. So if you see plaque or haziness in the presence of positive remodeling of the vessel, that is more atherosclerotic. If you see constrictive negative remodeling or the absence of positive remodeling, theoretically that is more suggestive of inflammatory process. So there is no positive remodeling here in the vessel.
So your argument is that this will be more likely to be arteritis?
More likely to be. I mean, my two-cent opinion of seeing one case. So I think that's the book description. That is the textbook description of the difference between the two.
Excuse me?
Is it cervical rib has been excluded? Cervical rib.
Okay, no, I don't think that was excluded completely. But I was honestly curious as to see whether or not what this was, whether or not we see a ton of inflammation, whether or not we just see classic atherosclerotic changes. So I elected to do HAWK on her. I did HAWK to remove some of the plaque so that we can send it for tissue diagnosis. The drug-coated balloon. Very importantly, you can see here there is actually a embolic protection device sitting in the brachial artery as well. So you want to protect the runoff as much as possible. Post-IVUS, you can actually see that there are some plaque that's removed, but there's still a decent amount even after the balloon angioplasty and the directional atherectomy as it comes here. Right here, you can see that there are some cuts made along the inferior border. There's some reasonable lumen gain, but still a lot of intimal plaque. And here's perhaps a little bit of hyperplasia here as well still.
Chung, can you tell us a little bit about the actual device? I mean, to do directional atherectomy here, we talk about bailout strategies and things you should be keeping in mind. You know, these arteritis patients, they respond very differently to insults to their vessels. Balloon angioplasty sometimes can lead to perforation when you're right-sized. Atherectomy, I would be obviously very concerned about the potential for even microperforation here. What was your thought of what were you going to do if there was something like that?
So I was good question. So I was very strategic. I wanted the small cutter. So directional atherectomy, as everyone knows, comes in different sizes. The smaller your device, the less cuts or the less robust cut that you will get. I believe in this case I used an M, so rather than using one of the L devices. So I didn't want a super robust cut. I wanted enough to send for tissue diagnosis.
Sorry, but can you comment about that? So just for the audience, how to based on the size of the vessel, because you're IVUSing, when to use S, M, or L?
So S, just for the audience, S is more for tibial artery. You can use it probably in the popliteal, but I don't actually carry S in my lab. We don't do a lot of tibial, we don't do essentially none tibial atherectomy. So we usually have M and L on our shelf. But you could argue if you wanted to make an even smaller cut, an S would be reasonable in this case if you're trying to protect the artery, if your clinical suspicion is high that it's more arteritis.
Did you ever consider thoracic outlet syndrome? Sometimes we see this disease pattern with like subclavian artery dissections or aneurysms that chronically embolize. And then if presumed to be arteritis, what was her inflammatory state by the time you brought her back?
So I had actually extensive conversation with my vascular surgeon who referred the patient as well as rheumatology regarding whether or not to even take this patient to the cath lab. And we discussed it multiple times, and it was her ESR and CRP have completely normalized, actually for months and months. And she was actually weaned off of steroids by the time that she came to see me. There was a high suspicion from the other members of the team that this was purely atherosclerosis, and hence why I was reassured that it was safe for us to take the patient. Okay, so we ended up fixing her left arm in a staged fashion as well. And the left arm, I did not have to do tissue diagnosis, so I actually just did gentle kind of chocolate plus drug-coated balloon, both completely normalized digital flow. And you can see the waveform change, the amplitude of the PVR is significantly improved in the left arm as well as the right arm. And as it turns out, her surgical path report showed that it was arterial plaque, much to my surprise, ultimately. I have a second case. This is a more traditional leg. This is a 62-year-old man with hypertension, diabetes, and prior surgical aortic valve replacement. Had prior stroke as well, affecting the left side of his body. He had a prior carotid stent for that. He comes in for left lower extremity claudication, Rutherford 3. He actually has ongoing smoking, which is 1 pack a day down from 2 packs a day, as well as recovering alcohol use. Underwent exercise regimen, but not really successful because of the prior stroke affecting the left side of his body. So very limited in terms of what he can do to help emphasize the supervised exercise therapy. He's on aspirin, statin, clopidogrel, ACE inhibitor, beta blockers, and hydrochlorothiazide. On his initial ABI, TBI, you can see the ankle brachial index is 0.44 with a essentially 0 toe brachial index. When we did his angiogram, what you can see is that he really falls in that category where you have a concave cap proximally and distally. In lesions like this, typically crossing antegrade and retrograde can be helpful. So indeed, that's what we did, antegrade with a stiff angle glide wire and then navy cross, and then same thing, retrograde with a stiff angle glide wire and a navy cross. We were able to rendezvous, externalize the retrograde catheter, confirm that we were true lumen distally, and IVUS was performed. Typically, if I'm crossing a chronic total occlusion, before I do any atherectomy, I do want to ensure that I'm truly in the lumen before we pull our device. So we confirmed throughout the segment of the CTO that we were true lumen throughout. Atherectomy with directional atherectomy, and this is actually one of the large devices, the LX, because it's a long segment, it's a large vessel. So we, with a longer chamber for collection, you can do more cuts, etc., and remove more plaque. So we did a directional atherectomy, did a drug-coated balloon, and what you can see here on the fourth, in the mid panel, is that there's actually a little bit of a dissection. Whoops, sorry. There's a little bit of a dissection flap right here. So I did do an additional directional atherectomy of that little flap, and we were fortunately able to avoid stenting with brisk flow in that area. So just a little plug for different devices that we used. Certainly, my partners up on the stage have already discussed some of the other atherectomy devices, but specifically for directional atherectomy, usually soft plaque and those with mild to moderate calcium, those are the most appropriate lesions for directional atherectomy. A little bit of information on this. So there was a systematic review from 2021 that looked at different devices, including directional atherectomy and orbital atherectomy compared to balloon angioplasty. Wanted to highlight here specifically that the comparison, depending on which trial you look at, was against POBA or PTA. And then there were more the recent trials looked at directional atherectomy versus a drug-coated balloon. And I highlighted this specifically because depending on the study, some of the patients actually did have CLTI, although 2 of the studies didn't really enroll high numbers of CLTI patients. And the TAS C and D lesions were not that high actually, so not really, real world patients, if you will. But at least in the 2020 study, there were about 50% of these patients kind of fell within C and D category. Regardless of how these designs of these trials, what you see across the board is that success and bailout stenting and then flow limiting dissection tended to be better, tended to trend better in favor of atherectomy compared to balloon angioplasty alone or a drug-coated balloon. There's a single center randomized trial, very small study with 60 patients only, looking at directional atherectomy versus orbital atherectomy along with drug-coated balloon. This was actually an IVUS-guided investigation. You can see here, just on the final kind of table that they showed, is that the bailout stenting is perhaps a little bit better in directional atherectomy, 7% versus 33%. And then there was, at least by IVUS interrogation, plaque reduction was significantly different between the two, meaning more plaque reduction with directional atherectomy because you're actively pulling out the clot. The plaque, as opposed to orbital atherectomy. No difference in perforation and no significant embolization when EPDs are used. Unknown, however, long-term patency rates and final clinical outcomes. So something to keep in mind. Yes, we do atherectomy sometimes in the appropriate patient, but we don't know the long-term outcomes of them compared to drug-coated balloon or stents. So takeaways, interventions of the upper extremity from the first case are particularly high risk. Very meticulous technique is needed. Always use embolic protection device, particularly for the hand. Intravascular imaging is important. Vasospasms of the hand, you have to really be vigilant about that. My hand cocktail really is nitroprusside and then nitroglycerin. In atypical presentations, do your homework and ensure that adequate workup is pursued. Thank you.
Thanks, June. In the interest of not going over into the next session, I'm going to ask our dear friend, Dr. Subhash Banerjee, to talk to us about atherectomy and the key drivers.
Thank you very much. You know, this discussion, why we perform atherectomy, has been debated, and there are a lot of positions. So let me use about 5 or 8 minutes to share my thoughts and how they're different. I think our other speakers have spoken about it. All the devices that you heard, whether they excise plaque through directional atherectomy, laser that burn or vaporize plaque, or orbital atherectomy that burn through the plaque, they're all grouped under the category of atherectomy devices. So these are adjunct devices, but not commonly standalone therapies. So my disclosures, let me go very quickly. There has been an ensuing debate that is not resolved. Why does atherectomy get used disproportionately in North America? And I think it is fairly used. The other data that is often presented, and this room has many stalwarts of atherectomy, is that atherectomy use suddenly took a huge hike after it got actually reimbursed through Medicare. And it's not uncommon, but its growth has been exponential. There are strong predilections based on geography, and of course, an equal split between claudicants and CLTI, at least based on these Medicare data. What was thought-provoking, that amongst all the important predictors and drivers of atherectomy, the location where the patient was having this procedure was one of the most important drivers of this. So let's dig a little deeper, and this created a whole host of factors, including, is it appropriate to use it? When should we use it? When should we not use it? Or are we overusing it? So, and why does the current data that June touched looks yet not definitive? Let me answer the question head on. These are CMS-derived data outcomes and reimbursement patterns of atherectomy in various locations. To your left is hospital outpatient procedures. The next is OBL or office-based procedures, and then ASCs or ambulatory surgical centers. Also, the endovascular in the peripheral realm, you can see atherectomy and non-atherectomy are actually equally split. So atherectomy is used nearly in 50% of cases. And most of the sites that use atherectomy in this analysis, about 80 or 85% of these cases are done in outpatient labs. So, but what are the key drivers of this will require a deep dive into these numbers, which I think we hope to provide in our research through our group. Let me provide the most important driver that you have heard again today, that if there are areas where stent placements are not required or not feasible or not ideal, those are non-stent zones. This is the common femoral artery where debulking or removing the plaque and then doing some sort of angioplasty is is a very, very good option. So atherectomy is used. This is another example wherein the distal superficial femoral artery, where near the adductor canal, you do not want to place a stent. You use a particular type of atherectomy. In this case, it was directional to treat this lesion and then treat it with a drug-coated balloon without stenting. This is popliteal and tibioperoneal trunk. This is orbital atherectomy with a distal filter. And post-orbital atherectomy, the lesion was treated with drug-coated balloon and balloon angioplasty, showing decent result, not excellent, again, outlining that these areas are important atherectomy zones because they are traditionally non-stent zones. This is one of my recent cases, which is actually not a great way where I should have used. This is an AT occlusion. It was crossed with a guide wire. Because the distal vessel was very small and suboptimal, I actually did not place a filter and I paid the price for it. You can see after using the smaller atherectomy directional cutter, the last angiographic flow shows sluggish flow in the AT. And despite a lot of vasodilators, you can see that the entire distal segment of the AT is not restored at the very end of the procedure. So atherectomy has a price, and that is why that question was asked, that filter placement and proper technique is actually very, very much required to achieve good results. But one of the most important drivers of atherectomy is the ability to not put in stents and prevent stents. Can you take it forward, please, the next slide? So the discussion that I want to hold, these are data from our registry, indicating that atherectomy use is approximately 30% in contemporary, because the data I showed from Medicare and before were from 2010 to 2018. These are more recent data. And second, that there is a strong association of long-term major adverse limb events, especially in chronic limb ischemia patients, if they actually end up getting a stent. So let's look into more, do atherectomy as an adjunctive device prevent placement of stents? Atherectomy, of course, also provide a lot of cost burden. You can see from our analysis of over 5,000 patients, whether you do a stent-based or a non-stent-based procedure, the majority of the cost of that procedure, if atherectomy is used, is derived from the use of the filter and of the cost of the atherectomy device. So I think we need to have proper, randomized, justified data to be able to use this technology going forward and put this debate to an end. June showed some slides. I'm just showing a different iteration of June, your data. This is Cochrane analysis of all atherectomy devices which have in some way compared head-to-head atherectomy to balloon angioplasty. And apart from lowering the need for acute stent, there is not durable long-term benefit, at least based on this Cochrane analysis. Now, let's switch gears and look at more contemporary data. And I'm drawing this as an example. So this is the DISRUPT-2 intravascular lithotripsy trial. If you notice why lithotripsy has become so popular and the results are so positive, is actually shown here. The primary endpoint of the procedure included both procedural success, that means a residual less than 30% was achieved, but also the ability to not stent that lesion. That was actually part of the primary endpoint. And you can see that there was a major difference in stent placements and major dissection. More importantly, the durability of the effect of intravascular lithotripsy in the DISRUPT-2, the secondary endpoint of primary patency at 1 year included freedom from stenting as part of it. And as you see here, most of the benefit at 1 year was derived from what happened at the time of the initial procedure. The freedom from target lesion revascularization and freedom from binary restenosis between angioplasty and IVL remain nearly similar. So the failure to put a stent after atherectomy or the ability to prevent a stent after atherectomy is a major driver of the benefit of these procedures. And I can tell you that Dr. Lawrence Garcia, hopefully is here, he's here, and he did definitive LE. I think that these trials would have looked very different if bailout stenting would have been included in the primary endpoint of many of these trials and not just major adverse limb events at 1 year. So let me show you femoropopliteal atherectomy analysis in about 5,000 patients. You can see that there is a strong difference in our registry from about 22 sites, that the stent rates are much lower, although the major adverse limb event rates do not show any difference. These are, of course, not randomized data, but these are core lab adjudicated consecutive cases to which I owe the blood and sweat of my team members who are here. If you look at major adverse limb events at 1 year, there is absolutely no difference, but a substantial difference in freedom from acute stenting. If you look at below the knee data, here you again see a less need for stenting in below the knee areas, which is actually very, very important. And although, at least in this limited analysis, you do see a trend or a marginal statistical significance in terms of difference in major adverse limb events at 1 year. So will freedom from stenting, if combined in future atherectomy trials, would lead to a different outcome and put an end to the debate that we keep hearing about justified data. My analytical team and many of who are here have done unbelievable work. This is going to be sent to TCT, looking at over 90,000 patients, again, from national EPIC data. Look, I can't get into the details of it because these are very preliminary data. However, again, you can see that the need for binary stenting and freedom from stenting is incremental with the use of adjunctive atherectomy. Of course, does it translate into meaningful results and outcomes is here to be discussed and in future trials. So my thoughts are that if we want to put in an end to this ensuing debate, what are the key drivers? Is it economical? Is it only clinical or combined? And do we achieve acute benefit or durable benefit? I think our team has just sent in an NIH R34, which is a design trial, going to compare, if funded, in a stratified fashion, atherectomy and no atherectomy with all conventional therapies allowed, where atherectomy is an adjunctive use during the intervention. And we have devised a careful win ratio-based hierarchical endpoint where we will stratify patient based upon freedom from major adverse limb events combined with freedom from stenting, of course, mortality, and then stepping down in the hierarchy so that we will truly be able to compare the true effect of an adjunctive therapy. So I'm not criticizing Disrupt. I think it was the right strategy, but I think future randomized clinical trials of atherectomy, if it includes this sort of a design, hopefully, of course, open to critique, will definitely put this question to rest about what are and what should be the key drivers of atherectomy. So thank you very much. I know I'm holding you for lunch, but maybe a minute for some comments, and then we'll go to the symposiums. And thank you all again for being here at CVI.
Any questions from the audience before we wrap up the session?
Can I ask a question?
Yes, please.
So we just mentioned many speakers and not everybody has all atherectomies in their lab. So how does operators in rural area and not academic who don't have all the tools choose? What do you guys recommend? Like most of the cases that you think like day-to-day bread and butter, what are the atherectomy or IVL catheter that should be in the lab to perform a good quality intervention?
That was a cop-out.
I'm gonna comment too.
I think that one ablative technique that I think that you really do need, and I did speak about this, is laser, but I also think that you can probably obviate a lot of the calcium compliance changes with IVL. So if you had to choose two things, I'd say I'd have those two things. But I think that if you could put in a third, I would definitely have one other form of atherectomy that is rotational.
Remember, laser's been around for a long time, but it's still FDA-approved indication for the treatment of in-stent restenosis, so I think it's an excellent adjunct, either alone, followed by a DCB, or followed by a covered stent for the treatment of in-stent restenosis. So we still pull out the laser. I think orbital atherectomy is still very useful, and it's in our lab the most commonly used atherectomy device. Our use of directional atherectomy has tapered off tremendously since the advent of IVL. So if I only had two, I would probably also go with laser and orbital.
Thank you. I think let's discuss this over lunch and attend the symposiums. Thank you again, and we'll reconvene at